Thank you for coming to our final talk in this hub today. So Petrina McKenzie is going to be doing a speech on becoming a psychological wellbeing practitioner. So over the past 17 years, Petrina has experience in the mental health service. So she's going to be given an overview on and the steps involved in becoming a psychological wellbeing practitioner from the application to completing your training. So I'll leave you to it, Petrina, and if there's any problems, I'll hop back in to tell you.
No problem. Okay, wonderful. Thank you. So, hello, everyone. So this is a little bit strange for me because I can't see the chat and all I can see is my presentation. And I had an experience a couple of months ago where I thought I'd given a really good presentation and found out that my Wi-Fi dropped out and I had been talking to my wardrobe for about 15 minutes. So this is kind of re-traumatizing, but I'm going to do my best shot. So I'm going to talk to you about becoming a psychological wellbeing practitioner. And first of all, I'm going to have a look at and talk about IAPT, improving access to psychological therapies, and how it came about and what that really looks like in terms of the step care model. And then we're going to look at the role of the psychological wellbeing practitioner itself and what you could be expected to be doing, the kind of elements of the role, what you would learn to become fully skilled in this role. We're going to talk about the training. We'll talk about the interview process, the application, that kind of thing, what you might expect in the interview as well, what we're really looking for in terms of those applications. Having sifted through so many, I can tell you which ones really kind of stand out and how to make yourself really come forward amongst all of those applicants. And also, it might be useful to know that if you're thinking this might be a career you might like to go into, there are currently 3 lots of trainee psychological wellbeing practitioner posts on NHS jobs today. Those posts are never up for very long, maybe 1 or 2, 3 days maybe at the most. So if that is something that you think would be great, and you this kind of piques your interest really, then I really would kind of encourage you to have a look at those and get those applications in quick. It closes fast because it's a very competitive role, because we're providing not only a paid placement, but also the university course is also paid for as well. So there's lots of competition for it, and lots of people see it as an excellent role in their journey within psychology. So, you know, we'll easily get 200 applications in the space of 2 days. So we always end up closing the advert early. So if it's something you want to do, then definitely get those applications in. So first of all, the acronym IAPT stands for Improving Access to Psychological Therapies. And that came about around 2008 following a report by Layard. And he identified that kind of a psychological therapy service would pay for itself with the money saved from the reduction in payments for incapacity benefit, and by allowing and enabling those people back into the workplace because their mental health would have been improved. And mental health services, particularly in primary care, were very much kind of patchy across England, really. Some areas had something, some areas had nothing. The type of therapy you would receive also varied dramatically, often staffed by registered mental health nurses who'd had, perhaps some training in counselling. But the different approaches you would find from those services would vary tremendously. So there's the Doncaster and Newham sites that came about. These demonstration sites demonstrated that CBT, cognitive behavioural therapy, was effective in treating people with common mental health problems, and they utilised a step care model, which I'll show you in a second. But IAPT is very much based on this step care model, and psychological wellbeing practitioners offer interventions at step 2. And the whole premise really behind the step care model is patients should be offered the least intrusive, NICE recommended treatment. So it's always kind of give the best chance of a positive outcome whilst burdening the patient as little as possible, really. So this is the step care model, okay? So I'm hoping you can see this. So you've got primary care, which is step 1, which is basically watchful waiting or an identification of the problem by the GP quite often. not all patients come via the GP now. There's a lot of self-referral, and people can refer via the website or phone up, so they don't have to have a GP referral anymore. So that's reduced one of the barriers to accessing the service. Then you've got step 2, low intensity therapy, which is delivered by us PWPs, and we treat mild to moderate depression and anxiety, looking at panic, general anxiety disorder, depression. NICE identifies that we can treat OCD, mild to moderate, although that doesn't happen within our service, because, to be honest with you, I have not seen, in all the years that I've worked, a mild to moderate case of OCD. OCD is far more better placed being treated by high intensity therapists. That's step 3. And step 3 therapists, high intensity therapists, can work with patients for longer. They have a greater toolbox, if you like, in terms of working with people with a variety of mental health difficulties, including post-traumatic stress disorder, social anxiety, and then the depressions, but more kind of mild to moderate and severe within the step 3 high intensity role. Also within the step 3, there's counsellors as well, IPT therapists, in that kind of step 3 kind of arena, really. So that's kind of the step care model. Patients don't always come via step 2 and then into step 3. They can't enter step 3 straight off. It varies from one service to another. Some services prefer patients who have gone through some kind of foundation kind of support, really, and some learning about the cognitive behavioural therapy model initially with a step 2 worker. But within our service, if your presentation is more around step 3, you can go directly into that. Okay, so the work of a psychological wellbeing practitioner. Okay, so we provide high volume, low intensity cognitive behavioural therapy. And I know I've been using the word cognitive behavioural therapy quite a bit, and I don't know how much you guys know about it. So I'm just going to explain it a little bit. Basically, our assessments look at the patient in terms of their physical feelings, their thoughts and behaviours, and how they get stuck in certain cycles. And our treatments look at how we can break that cycle with the patient. So if I give you a bit of an example. So physical symptoms for depression, for example, my sleep is poor, I'm tearful, I'm exhausted, I'm tired. In terms of my behaviours, I'm avoiding things that I used to enjoy, I just don't have the interest in them anymore. I'm avoiding my friends. I'm avoiding doing some of the necessary tasks that I've got to do. I just don't feel like doing them anymore, so I'm not doing them. And because of that, my thoughts are, I'm useless, things are hopeless, I don't have any worth, people don't care about me. So, you know, that's kind of an example of someone's kind of cycle if they were experiencing low mood, for example. And we'd talk with the patient about how you can break that cycle. And we might look at the behaviours and do something called behavioural activation at step 2, which is looking back, getting back into doing things pleasurable, routine and necessary. Or we might kind of consider with a patient looking at their thoughts and thinking about something along the lines of cognitive restructuring, which is looking at those negative thought patterns and looking at how true those thoughts are. So for quite often, patients will kind of experience lots of negative thoughts, and it's identifying that just because I have that thought doesn't mean it's true. And actually, when we look at that thought and we look at the evidence for it, quite often there's very little evidence for that thought. Okay, and it's not. Some people think that this kind of thought challenging is about positive thinking. It's not. It's about looking at the balance in that thought and looking at actually, should I hold on to this? Am I doing myself a disservice by thinking this? Or do I have to acknowledge that actually there's very little truth or no truth at all in this thought, and it is just a thought? Because thoughts can be very powerful. And actually working with a patient and helping them appreciate how, the physical feelings, their thoughts and the behaviours have kind of got them stuck in this cycle can be really powerful in helping them understand where they're at the moment and how they're going to move forward. Because step 2 CBT guided self-help is very much a goal kind of orientated therapy. We're looking at doing activities with that patient to get them to where they want to be in terms of helping them improve how they're feeling, so that they feel better in themselves and more able to cope with the things that are happening around them. So that's basically the assessment part. We also look within that assessment at drug and alcohol use. We look at things that are moderating factors, safety behaviours, things that make the problem better or worse. We look at risk as well, which I'm going to come on to. So in terms of assessing risk, we look at suicide risk and risk to self and risk to others. And quite often trainees who come into our service, they have an idea of what IAPT will be like, and when they actually get to do assessments, they realise that actually quite often there is risk with the patients that we're assessing, because patients can self-refer. So they can be presenting with all types of mental health difficulties. And yes, we're looking for people and patients who are experiencing depression and anxiety with our service, but we also complete secondary care referrals for patients who are experiencing or have the symptoms of things like personality disorder or complex trauma or psychosis and things like that. But in terms of risk, there will be patients who have thoughts about ending their life. There will be patients who have planned on how they will do that and score their intent to act on those thoughts highly and have attempted to do that in the past. And we have to act on those risks and ensure that we're supporting that patient properly and we're getting them the additional support they need through crisis team and their GP. So sometimes trainee PWPs are surprised at the types of patients that we are assessing, but we can be assessing patients from all different spectrums of within mental health. In terms of safeguarding as well, that's another responsibility that we have, and we ask about patients' dependence, and we ask about whether they are having any difficulty in looking after those children, but also we ask questions around historical sexual abuse, and we have a duty of care to report any concerns around that. But also thinking about safeguarding children currently in terms of relationships where there is domestic violence or drug and alcohol use. That's also something that we have to think about and act upon, and are responsible for doing so. Like I was saying, we also signpost to secondary care services for patients with more severe mental health experiences. And we also refer and signpost to external services, for example, domestic violence services, services for different types of counselling, specific counselling, sexual abuse counselling, those kind of things, because the patient's needs can be better met by those types of services. On average, step 2 PWP treatment sessions are for around 6 sessions of guided self-help, half an hour treatment sessions, normally every week or every other week. Assessments in our service are an hour, but that can vary from one service to another. I know that some services prefer to do their assessments in half an hour. That's not something that our service would be able to do, given the complexity of the patients that we are assessing quite often. Clinical hours are split between assessment and treatment, and that can vary depending on the service's need. All PWPs and trainee PWPs have case management supervision, where you discuss the patients you've been assessing. So you're not alone in making those treatment decisions and choices. You're not alone in terms of having to work through what to do with risk and safeguarding. There are people there to support you doing that, and that's part of the role that I have currently as well. And within case management supervision, we discuss the treatment pathway, we look at recovery rates. IAPT is very much based on numbers. So it's numbers of clinical contact hours, it's numbers of patients through the service, it's numbers of patients who've recovered. We're very heavy on that kind of data, really. And in lots of ways it's good, because you want to be working within a service where patients recover, because that's the point. And you'd be concerned if your service had a poor recovery rate, and that would need to be looked at and thought about and identify the reasons why, so that can be improved. But also in clinical case management supervision, we also look at hurdles and barriers that can come up for patients in terms of their treatment. So we do all those kind of things. And we also provide clinical skills sessions which support PWPs and trainee PWPs in developing their skills with patients further, and their knowledge and awareness of step 2 treatments and sharing patient kind of patient stories that people they've worked with and what's gone well and what hasn't gone well, and just working very much as a team really in supporting each other in doing that. So being a PWP, the best things really about being a PWP is being part of someone's recovery, okay? And every patient is always different. So I have worked in mental health for over 17 years, and I've worked within IAPT for around 9 years. So I've been doing this role for a significant amount of time, and every patient is always different. Whether you were to assess 5 depressed patients in one day, they will all have their individual stories and their varying degree of different symptoms. And it's really, to me, it's an honour to be trusted with someone's experience and to feel that they feel able to talk to me about how they've been feeling, because that's really difficult in itself for lots of people. And you're always learning and growing as a practitioner, because every patient is always different, like I said. So we deliver low intensity cognitive behavioural therapy interventions that are all evidence-based. So we do things like behavioural activation, which I spoke a little bit about earlier, cognitive restructuring. We do something called worry time, which basically looks at getting a patient to give themselves permission to worry at a certain time of day. And it sounds a little bit strange, and patients always look at us a little bit skeptical about it. But basically what it is it's getting people to give themselves permission to worry at a certain point in the day, but taking away that worry that kind of is constant, that constant worry, the worry before they go to bed, the worry when they get up, the worry that's so distracting from everything else that they need to do. They write them down and they give themselves permission to look at those worries, so that then they can identify whether the worry is hypothetical and something that they have to let go of, or a worry that they can problem solve. And that for lots of patients is really helpful, just giving yourself permission to worry, because worry would inevitably keep saying to yourself, I shouldn't think about that, I shouldn't think about that. But if I was to say to you guys, don't think about a skating penguin, right, for 30 seconds, I'm thinking, and I wish I could see you all so I could ask you, I'm betting that for quite a lot of you, that skating penguin will be there, because thought suppression doesn't work. We can't tell ourselves not to think of something because it will keep popping back. But when we say to ourselves, okay, that's a worry that I've got right now, but this is not worry time, so I'll keep that and collect that for later, and I will focus on it and give it time and permission to look at that for lots of people is really, really empowering in terms of just controlling the time that they spend worrying, giving themselves some time back, and learning a way and a strategy of managing that worry, which is far more productive. And those hypothetical worries that often they will notice again the second, third day, and again in subsequent days, they're not as powerful because they've already considered those things and they've already looked at those things. Other interventions we do, we look at panic and panic psychoeducation. So if I give you an example of a panic cycle using the cognitive behavioural therapy model. So for example, physical symptoms, heart sweaty, palpitations, heart racing, behaviours, either avoidance of the situation that makes them feel panicky, escape from that situation, perhaps potentially lots of safety behaviours. So I might carry a bottle of water with me, I might have my headphones with me, I might stare at my phone continually so no one can look at me and speak to me because I'm obviously too busy. I'll just scroll through my phone. So lots of kind of behaviours there that I might do. Thoughts, I'm going to die, I'm going to pass out, everyone can see I'm panicking, this is terrible, all those kind of things. So with that kind of presentation, what we look at is kind of getting someone to think about, okay, so when you have those physical symptoms, you feel hot, you feel sweaty, your heart's racing, and you think, I'm going to die, I'm going to pass out, what happens to those physical symptoms? The likelihood is that those physical symptoms get worse. Because if I thought I was going to die, my heart would race far more. Okay, so just working through that cycle in itself can help the patient identify what's going on. And if I know what's going on, then I can work at ways of stopping that cycle. So what we would do is we would give the patient some tools to learn progressive muscle relaxation, and they'd practice that frequently for several weeks. And the idea is that you learn these techniques so that you can learn some breathing techniques, you learn how to let go of tension, so that if you can find points in your day where your anxiety is building, you can feel that that is building, it's going to become a panic attack. You can implement those strategies there to stop those physical symptoms from increasing to the point where you do panic. But also, if you do find you're having those physical symptoms, rather than thinking, I'm going to pass out, I'm going to die, thinking, actually, I'm just feeling really anxious because of X, Y, and Z, and this is okay, and these physical symptoms will pass. You're not going to peddle that anxiety. You're not going to make, that cycle worse, if you like. You're going to kind of stop it there. So by supporting patients in learning about their cycle can be really useful. And again, in terms of panic, if they're avoiding situations, in the short term, avoidance for both depression and anxiety is rewarding, because I don't have to do that. I don't have to feel those symptoms. With depression, if I avoid things, I'm likely to feel worse because I haven't done them, or I haven't seen my friends, or I haven't just given myself a break from all the other things and done something that actually might have enjoyed because I don't have the motivation. Whereas for anxiety, that avoidance is also rewarding, because I don't want to put myself in that situation because I feel hot, because I feel sweaty, because I feel anxious. And those anxiety symptoms are very uncomfortable, especially when they become panic. So it's kind of really exploring those cycles with patients can be really integral in helping them work through how they're feeling. And it can make such a difference. The step 2 treatments can sound quite simplistic, and in some respects, perhaps they are. However, when you're stuck and feeling very stressed or very anxious or very depressed, sometimes the simple things, you can't see them. We can't see the way forward. It's kind of like just being stuck in mud and not being able to see which way is the best direction for me, because I feel I've got so many things on my plate. I can't do it. I can't focus on things. I can't identify which way forward will be best for me. So it's kind of really, really working with patients with these techniques. And we do that in lots of different ways. So PWPs are really lucky because we can deliver our treatment in different ways. So we can do it face to face, although no, we're not doing that very much at the moment because of COVID-19. We have moved far more to telephone, far more to things like we have an online package called Silver Cloud, which we can support patients with. We also run groups. We're running groups on Microsoft Teams at the moment as well. So there's lots of different ways that we can support patients and deliver our treatments in a way that patients can access them. And just having a whole variety of modes that patients can access treatment, opens it up to a far greater number of people. And it can fit around work. It can, it's far more better for patients to be able to access these treatments in lots of different ways, so they can pick the one that will be better for them. And just thinking about COVID-19, I wanted to discuss a little bit about the types of patients that we've been seeing within the service and how they've been presenting really. So at the start of lockdown, we had a lot more patients who were disclosing childhood sexual abuse, for many of them for the first time. And my kind of feeling on that is that the first lockdown, gave a lot of time for thinking, and whereas patients might have been distracted with lots of different activities, work, social events and all those kind of things, because they all stopped, it gave a lot of opportunity for thinking, and sometimes these things came to the forefront far more and felt far more distressing because the distraction wasn't there. We've also been having patients who are experiencing post-traumatic stress disorder as a result of being in intensive care. So those patients are certainly coming through now. Patients who are experiencing loneliness, and loneliness amongst younger people as well. We're finding it difficult in some respects because there's lots of different services out there for older people who are lonely, But for younger people, there seems to be the perception, well, you've got all this kind of social media and all those kind of things, and you can access people in lots of different ways, you'll be okay. But actually, we're finding loneliness is a big theme amongst young people at the moment, and that young people are finding that really quite difficult. Grief and loss, patients who've lost and been bereaved during the COVID lockdown, not necessarily from COVID itself, but from they've been bereaved for other reasons, and because of the COVID-19 lockdown, weren't able to grieve properly, weren't able to be with that person in their final hours. That also has been difficult. And also, people have not had those social resources they were used to. The people that would just go and see and talk to, or have round or have a coffee with, just not been possible. And those things are also impacting on patients. And we've got also the financial consequences of the lockdown as well, and the stresses that are causing for patients, and patients losing businesses that they've built up over many years and sacrificed a lot for. Their business is gone, and that is very difficult. So lots of different losses that patients are experiencing because of the lockdown. So thinking again about the role itself, so in addition to the kind of day-to-day stuff, we also encourage our PGPs to be involved in other things. So we have champions for the service user forum that we run, a digital champion, for example, as well. And as experience and confidence grows as a PWP, we encourage our staff to access supervisor training and things like that. So there are lots of different options available and things to get involved in as a PWP, and you can really make the role your own in lots of ways. So what is life like as a trainee PWP? Well, I'll say this to you. It's difficult, okay? Don't ever underestimate the trainee PWP course, because it is very hard in lots of different ways, because the service is making demands of you, university will make demands of you as well, and meeting those is difficult, and it is stressful, but it is very rewarding, and you will learn an awful lot. But you all learn an awful lot in a very short period of time. And I think that adds to the pressure as well. So what you learn at university is complemented by what you'll do in service. So you'll do your assessment module first, and then treatment, and then values, diversity and context. When you do your assessment module, once you've started that, you'll then start to do assessments within the service, and we support and our staff doing those. And then you go on to treatments, and as you start the treat module and you've learned some of the treatments, you start to see patients for treatment. But it is intense. So you have 2 days at university and 3 days in service, and you're paid at a band 4. And when you qualify, you then are paid at a band 5. And within our service, PWPs can earn from a band 5 all the way up to the top of band 6. So it's quite a broad spectrum of across the pay bands, which is a good thing. So the support and experience in the service, like I said, really complements the university learning. There is a lot of work involved. Different courses require you to do different things, but all of them will require you to do a recording of assessment and a recording of a treatment, which is a passing assessment and a passing treatment, to demonstrate your skills with patients and how you can follow the kind of structure of the low intensity model. Lots of them also include different essays and coursework and things like that, and different kind of logging of your own kind of personal reflections. So you're encouraged to kind of utilize the techniques on yourself, so you can reflect on how they work or don't work for you, and kind of problem solve those for yourself. And by being under no illusions, this course requires you to do additional work in the weekends and the evenings and things like that. It's not a 9 till 5, because it's a university course as well. The other thing that's worth saying is it's a graduate and or postgraduate level certificate. So you don't have to have a degree to do this training, which is really, in lots of ways, fantastic. But you do need experience, and that's what I'm going to go into in a second, because competition is seriously fierce. Okay, so if you're going to apply, you really need to stand out to get that interview, because I end up going through 200 applications, and if you're not demonstrating that you have an understanding of IAPT, that you have some experience of working with patients with either common mental health problems or with mental health difficulties in different settings, whether that's secondary care, primary care, voluntary sector, whatever. If you don't show that you've got that experience, you're very unlikely to progress despite having maybe a degree in psychology, because that in itself is not enough. And you don't need a psychology degree. The experience is far more important than anything else. You can get that experience, paid or voluntary work is good, but it's ensuring that you've got that, really, because that in essence will help you know whether this is the type of work you want to do, because there is no nice lit room that you'll be working with while the patient lays on a couch and is just a little bit depressed or a little bit anxious. It isn't like that. Okay, in lots of services there was lots of kind of difficulties that patients are experiencing, and they're quite often quite complex as well, and we're working with high caseloads and high volume, so there is no chaise lounge where the patient lies down where you write with behind them with a clipboard. It's a very psychodynamic example anyway. Quite often when prior to lockdown, we were all kind of doing telephone assessments in very close proximity to other staff as well. It's very high paced and very high volume, so it's good to really have a good idea that this is something you want to do, and this is something you want to invest your time in. Read the literature and prepare for your interview. Okay, so at the end of my presentation there are some links that are hopefully quite useful, but it's useful to have a look at background to IAPT. It's useful to have a look at what NICE are saying in terms of guidance for working with people with common mental health problems at step 2 and step 3. All those kind of things are useful. In terms of the role play, when I'm interviewing people, I'm not looking for you to be able to do an assessment as you would as a PWP. What I am looking for is that you can demonstrate empathy, you've got good listening skills, you're able to reflect back what the patient has said, there is interest from you, there's a variation in your tone, a supportive manner. All those kind of things are really key if you're going to do a role play. Sometimes the PWP trainee interviews can feel like the X factor. There's a first stage, a second stage, a role play, a presentation, all sorts of things that they can throw at you. So really be prepared for that, and also have a think about the service you're going to be applying for. Have a think about the demographic of those patients, and have a look at the additional services that are around in that area as well. Have a look at the website of the service you're going for an interview for. All those things will give you ideas and information that would be helpful. I know that for lots of trainee PWPs, they travel around to different services, but when we're investing in you, our time to get you through that course, we want to feel like you want to work for the service you're doing your training with, even if that perhaps is not the case, but we want to get that feeling from you that that's something you want to do. Relate your experience to the job specification. So sometimes it's really telling when people have cut and paste a person spec that they've used for 5 or 6 other different other jobs. Is not helpful. I want to feel that you want this job and you've written accordingly to what is in the person specification, because that's what we're marking you against ultimately. And if you can tick off those elements in the person spec, you're far more likely to get that interview. And think about your well-being as well, because this type of work, it isn't easy. It's about thinking about how you will be boundaried, how you will look after your own well-being. And sometimes these questions about your own well-being and managing your time and things like that will also come up in the interview. So it's good to have a think about that and how you look after yourself and what kind of things you do help to make you feel well. So thinking about areas for progression. So once you've passed the training course and you've been a PWP for a while, there are different areas that you can progress within IAPT and also outside of IAPT. So you can work to become a senior psychological wellbeing practitioner like myself, and we manage the PWPs and the trainees provide case management, line management, look at and support our staff. We provide training to the team, all those kind of things. Provide reports and things about accountability and recovery rates and targets, all those kind of things. We report back. We work with the leadership team to ensure that the PWPs are happy and supported in their role, and that things that are coming down from senior management are doable and achievable. You could look to become a high intensity therapist and work at step 3. So I talked about that a little bit earlier. And that training is a year's training. And again, at the moment, those training places are paid for. Okay. And a PWP role also is a popular route for people who want to train as clinical psychologists as well. So that's another area you might want to think about if that's something that you're looking at, because it does give you an excellent range of skills and experience of working with a whole variety of people experiencing mental health conditions. Because although we work with mild to moderate depression and anxiety at step 2, we assess patients with all sorts of presentations. So it does give you a good basis if that's something you want to apply for. So that's really all of the presentation that I've got. There's some useful websites there as well that are worth having a look at. The reach out guide is really useful. So if you've got an interview coming up for a trainee PWP job, really have a look at that, because it goes through what you do at assessment, it goes through common factor skills, it looks at what you do at treatment. Very, very useful. Again, the IAP manual is good. Low intensity IAP handbooks are available on the Cedar Exeter website there. You can have a look at the different workbooks that we use in treatment with some of our patients. The CBT resource is another excellent resource. Not a low intensity guru, the life and times of IAP low intensity therapist. That's an excellent. It has some excellent information and provides some really useful insight into looking at what it would be like to be a PWP and the kind of work that we do. So I'm hoping that you've not all disappeared. And I haven't been talking to the wall for half an hour.
I've been able to hear you. Hi. I mean, if you want to put your camera on now, I think it should work okay. Yeah.
Okay. I've stuck it on, so I might appear. There I am. So I don't know if that was okay. I was really anxious, as I was saying at the beginning of my presentation, from my previous experience of talking to my wardrobe for half an hour. So I hope that was okay. I just wondered if anyone has any questions for me.
Yeah, there's a couple in the chat if you can see them, or if you want me to read them. Yeah.
I can't see them, so
it says, is it possible to enter the PWP from a different career?
Yes, it is. You don't need to have a psychology degree. You don't need to have a mental health background. You can enter from a different career, but you need to show that you've got some experience in working with people with mental health problems, voluntary or paid or whatever. But it's good to have that experience, because really to get through onto the interview itself, you need that, because like I said, we get a lot of applications and it's really quite tough to get through.
Brooke asks, how would I approach becoming a nursery nurse? Yeah.
A nursery nurse?
Yeah, I was thinking.
I don't know.
Okay. So we had a question asking what jobs are similar to these ones, or this one.
Okay, so similar to a PWP. In some services, they have assistant PWPs. But for lots of services they do that, they usually intend to put those people into trainee posts. There were, I guess, in some settings, there's something called a social prescriber. And you get support worker roles and things like that. I guess those have some similarities, although they don't deliver the kind of guided CBT that you do with as a PWP. So they're kind of supportive roles, but not without the kind of.
Sorry, I don't know if you can hear those fireworks going off there.
Oh, okay.
So then we had, do you think child and adolescent mental health degree is suitable for being a trainee PWP?
Yeah, but there are also child and adolescent mental health PWPs. There are PWPs who work with children and adolescents specifically. So there's maybe two branches that you might want to consider there. But yeah, certainly, because as long as you're showing you've got experience. I mean, the thing is, we work with patients from age 16 plus, so there is some bridge there anyway. But as long as you're showing that you've got experience of working with people with mental health conditions in whatever respect that might be, it's likely to help that application. It might be worth getting a little bit of adult experience as well to kind of back that up. But there are roles for children and adolescent PWP workers specifically.
We had someone's asking, what setting do you work in?
At the moment, I work from home. But before COVID and everything, we used to work in community centres and GP surgeries, all short start centres, all those kind of places where people can access them easily and they've got all the access needs there. So we would work in those kind of settings. But we do provide a lot of work over the phone or online at the moment because of the situation itself. But I anticipate when things improve that there will be more face-to-face work. We are delivering some face-to-face work.
Are you doing your stuff on phones, or are you doing it via sort of Zoom things?
Yeah, some of it is video conferencing. Certainly telephone for other patients. It depends on the patient's preference really, and what technology they feel comfortable with and they have access to. So for some patients, they don't have access to the internet or a device that they can access it on. So telephone for some patients.
And some PWPs, do they work in a specific, say, in a GP's, or does everyone move around from different?
Yeah, it tends to be everyone moving around because it's nice. It gives them a nice variety in what they do. We try and mix things up because it keeps the job interesting and fresh.
Someone says, do you have any advice on how to get experience?
In terms of experience, in terms of mental health experience, lots of charities and things like that will give you the opportunity to do some work for them voluntarily. Samaritans, for example, we have an organisation called the Richmond Fellowship in Leicester. They would, it's just looking on these different organisations' websites and seeing what roles they have for volunteers really. But certainly there's those kind of opportunities, and there are some paid opportunities as well. It's just seeking those out really. But yeah, the more experience you can get, the more it will help, and also help you think about whether this is a career that I want to do, because it's not easy. Listen to other people's difficulties every day. So it's whether you feel that you can kind of manage that as well, because sometimes people's experiences can be quite horrific, and really distressing things people have been through. You can't even imagine. So sometimes we listen to some patients who've had some awful experiences, and it's kind of thinking, am I able to do that? Is that something that I want to do? Because you do end up giving something of yourself when you're doing this job.
And with the experience, and you saying Samaritans, are you thinking that you're still being able to get experience during Corona with Samaritan lines and stuff?
Well, yeah, I mean, they do a lot of online work, and they do telephone work as well. So I think that is something. I mean, Samaritans will have been very busy, so I'm pretty sure that they would have opportunities to work for them and volunteer for them, because they're a great resource available 24/7 for patients and people who are finding things very difficult. And with COVID, we are finding that the second pandemic will be mental health.
Yeah,
and
definitely.
the impact it's had on so many.
We had, how difficult are the university assessments? Are they similar to undergraduate?
The essays and things are pretty similar. There's a little bit of additional, I suppose, critical thinking and stuff and things like that post-grad, but the most difficult thing is the actual recordings of the assessments and the treatments, because you have to follow the protocols, but you're taught those and you get lots of practice. And when you're working in a service, your service will practice with you because we want you to pass. But it is difficult and it is hard work.
There was one similar, but I'll ask it just in case. What kind of experience do trainee PWPs usually have? I guess that's quite similar to the question before.
Yeah, I mean, quite often they've worked either in a mental health setting, not necessarily as a clinical member of staff, but sometimes in a mental health setting, sometimes in admin, for example, but they've been answering the phones to patients, so they've had opportunity to develop that kind of rapport. So those kind of settings, secondary care, healthcare assistants, for example, we get quite a lot of those people from those kind of backgrounds applying. People who've worked with Samaritans or those kind of advice lines on a voluntary basis as well. We get lots of people who come with that kind of experience. But it is, very much thinking about how your skill set would be useful in working within the IUP service as a trainee PWP.
So we had a question. Aside from supervision, how do you manage your well-being due to the cases you're presented with?
Yeah, I mean, supervision is really useful because we can talk through that case, but not just talk through the patient in terms of what the pathway would be best for them, but also how it's kind of made us feel. A reflective space that I've set up within our service with one of my colleagues to give staff the opportunity just to kind of go through patients in a smaller group, because now because of lockdown, it's hard on Teams when you've got 25 members of staff on Teams. It doesn't really work very well. So we're having smaller groups where we can kind of use those as a reflective space to talk about patients that we found difficult or were difficult to listen to. And their experiences are kind of either might have resonated with us or it kind of brought up feelings within us. So we can kind of discuss those. And we're very supportive of each other. But also wellbeing is not just within work, it's also thinking about what you're doing for yourself outside of work. And making sure that you're doing things that you enjoy, your hobbies, those kind of things, but also just basic things of taking your lunch break and finishing on time and not logging on and checking things and making sure that your work stays within your work time and doesn't spill over, but using supervision, using your line manager, but also ensuring that things you need to do that keep you well, keep you happy, continue. And if they stop, then thinking and reflecting on that, why am I not doing those things anymore? Am I finding things more difficult? And saying if things are hard as well, and feeling that you can talk to the staff and your line manager and your case supervisor about it. So actually, this is not great for me at the moment. I need to talk about it, because you have to look after your own mental health to be able to look after other people's.
Following on from that, someone said, how do you know if you are mentally equipped for this job?
It's hard to know, but that's why I'm suggesting that a good thing to do is to do the voluntary work first, to see whether actually this is something that I can see myself doing, because sometimes we have this image of what it will be like, and when we get there it's not. And in our service there's a whole lot of complexity and risk, that we have to deal with as PWPs, and quite often trainees don't anticipate that because it's sold as being mild to moderate, and that's who we treat, but that's not who we've ended up assessing. And there is a mismatch in some respects of what the university course teaches you in comparison to what you actually do in service. Things have changed over the years, and the course perhaps has not necessarily kept up with changes. But yeah, if you get yourself some experience and do some voluntary work that you can dip in and dip out of, then that will help you know whether actually this is something that I feel able to do and I want to do. Well, I know I've kind of talked a little bit about some of the kind of things about thinking about your boundaries and things like that, but you know, it is a fantastic job. It's a wonderful job. It's a wonderful thing to be part of someone else's recovery and be part of that, and to support someone in identifying what is making things difficult for them and helping them change things. You know, to be part of that it's fantastic. But it's also thinking about, because the high volume, is there something that is going to be okay for
we
them?
had a question: what uni courses would you say are relevant to this training?
Well, the training itself, you obviously go on the university course. To me, university courses are fantastic, and they show that you can study at a certain level, and they're very useful. But like I said, you don't have to have a university qualification for this role. You can have the experience and study the course at a graduate level rather than a postgraduate level, and you can do very well. I know we've had lots of staff who've been in that position because their experience outweighs that in lots of ways, and makes, you know, for patients, they want someone who can listen to them and cares about what they're saying and their experiences, and can identify in some respects with how they're feeling, can support them during their treatment, cares about their treatment journey, is interested in them. That's not something you've either got that or you haven't, I think, and you don't need the university qualification to demonstrate you've got that to be able to get
that makes a lot of sense.
Training.
Is there any other questions that anyone has? Give it a little while for people to type. I'll just give a check up in the chat, check I didn't miss any questions. I think that's all the questions that we've got. And
yeah, we should have this firework display, shouldn't we? I can hear it, but it would be good to have that.
Thank you so much for coming and talking to us. It was a really useful talk that I think everyone enjoyed, and we've had a lot of questions come back, so I think everyone else really enjoyed it, and I hope that everyone's learned a lot from it.
Thank you. And if anyone has that interview coming up or you know, is looking at applying, you know, I'm happy for anyone to contact me on LinkedIn. So if you want to ask me any questions after this, or
I was going to say to put your details in the chat, but you can't see it. But I think the recording. I mean, if you want me to put it in, I can put it in, or the recording with this will be going online later.
Okay. Yeah, I mean, if you go on LinkedIn, just put Petrina McKenzie and it will come up anyway.
Well, thank you so much for coming to talk to us today. You were an amazing last speech for us to finish on this hub. Wow. Thank you. Bye.
Thank you. Bye, everyone.